Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear from Dr. Shana McCormick from Children's Hospital of Philadelphia. Our moderator for the Q&A this evening is our very own Margaret Moore, UMDF Support and Education Associate. Let's get started, Margaret.
Welcome, everyone. I want to get started by thanking our sponsors, Edith Eltree's Charitable Trust, just a little bit of housekeeping. If you have any questions, please place them in the Q&A. You can see the Q&A button at the bottom of your screen. It has two little bubbles. Please utilize that for questions and not the chat. You can use the chat if you're having technology difficulty, though. We have closed captioning. You should be able to turn that on at the bottom of your screen. For more in-depth descriptions of that, Nicole has placed that in the chat for you to read. If you have any trouble with it, please just ping us. Next slide. All right, I am happy to introduce Dr. Shana McCormick. Would you like to come off screen off of mute real quick? So Dr. McCormick is an attending physician and scientific director of the Neuroendocrine Center in the Division of Endocrinology and Diabetes at the Children's Hospital of Philadelphia. And she also serves as a member of the clinical research team for mitochondrial medicine at CHOP. So welcome, Dr. McCormick. We're really excited to have you here and to see what you're going to be filling us in on about the endocrine system in patients with Mito. I know we're going to have a lot of questions and lots of information to cover today. So let's get started. I'm going to pop off screen and your presentation will pop up there and we'll be ready to go.
That sounds great. Thank you so much for that kind introduction. Before you pop off, can you see those slides okay?
Yes.
Awesome. Thank you so much. Thank you for the kind introduction, and thank you to the group for letting me speak with you. Each time I speak to UMDF audience, I get terrific questions and have an opportunity to reflect and learn. So thank you again for inviting me. So as was mentioned, the title of my talk is Endocrine Complications of Mitochondrial Disease. I have a lot of people to thank who teach me about these conditions, most notably are my patients, of course, but also Amy Goldstein and Marnie Falk from CHOP. My colleague David Weber from the CHOP Bone Health Center was very much hoping to join me and to tag team this talk, but he unfortunately had to travel, but he's given me some slides, so I'll use his borrowed expertise. So this group well knows that mitochondrial disorders really can impact any organ in the body, and the endocrine system is no exception. And in fact, many endocrinopathies, endocrine problems have been associated with mitochondrial disease. Endocrine manifestations, which are shown here in this schematic, include short stature, so less than optimal growth in children, hypoparathyroidism, problems with calcium levels, adrenal insufficiency, problems with the hormones of the adrenal gland that help our bodies respond to stress, diabetes, this one's in bold because it's fairly common and very important. Also hypogonadism, so problems with sex steroids. Pregnancy-related complications are also really important beyond my expertise though, so I won't be touching on those. An interesting point to make, and that is worth talking about with your care team, is that certain subtypes of mitochondrial disorders have increased likelihood of endocrine disease. And you'll see some of those highlighted in the examples that I share in the talk. I decided to focus, and I've focused on some patient support talks this year, really on blood sugar related problems, because I see those so commonly, and there's such an area of concern. But problems related to blood sugar are also influenced by other hormone problems. And so I'm going to touch on those as well. And folks with blood sugar problems in particular, as well as others with mitochondrial disease, are often those who have problems with bone health and fracture. So I have a few slides from my colleague, Dr. Weber, kind of bone 101 to talk with after we review some of these other topics. All right. So this is kind of what we're going to cover: diabetes mellitus, and hypoglycemia, adrenal problems that affect blood sugar, growth problems, including growth hormone deficiency that can influence blood sugar risk. I'm not going into detail on calcium. I'll give a little brief primer. Won't discuss thyroid, weight gain, sex steroids, but there's some resources, and certainly if folks have questions in the Q&A, we can review some of those. So why it's important to me to give talks like this one, I was just talking with our colleagues before the session started. If you are a well-informed patient or support person or family member, you can have thoughtful conversations with your endocrinologist and find endocrine problems early and treat them. So most endocrine problems may not be curable, but they may have effective treatments. So one of our students in years past, Iman Al-Ghadi, who is now herself an endocrinologist, looked in the North American Mitochondrial Disease Consortium and looked at the burden of endocrine disorders in 404 individuals with molecular diagnoses of mitochondrial disease. And she found one of the most common problems was atypical growth and sexual maturation. So less than optimal linear growth in children, being shorter than they might expect, delays in puberty or early puberty or difficulties during puberty. The prevalence of diabetes in this cohort was 13%, although that varies across different cohorts that we study, and hypothyroidism. And these were the endocrine diagnoses that were collected systematically, but the ones that clinicians also wrote in included the ones who are listed here, the ones that we'll talk about today. Another point to mention, a couple, we have a trainee, Herodes Guzman, who is following up on some of these findings to update these and look more at prevalence in different subtypes. But also I saw in the chat that patient registry volunteer opportunities are offered to folks. And I would just encourage you to consider participation, because we're able to use those types of registries to generate really important data like this one that guide our clinicians as far as screening practices. So drilling down a little bit into blood sugar, into glucose, this is a diagram that summarizes a little bit about how I think about sugar and blood sugar and nutrients in mitochondrial disease. So on this x-axis here is nutrient availability, how much nutrition is around. And on the y-axis is what happens with blood sugar. And in healthy individuals, shown in green, even if they get maybe more nutrition than they need, like they overeat, or they get less nutrition than they might need, like they're fasted, they can keep their blood sugar in a typically safe range. In contrast, in red, folks with metabolic and mitochondrial disorders, too much or for sure too little nutrition leaves them vulnerable to fluctuations or extremes in blood sugar. So keeping folks in the sweet spot, forgive the pun, can be more challenging. So we'll talk a little bit more about that. Turning our attention first to high blood sugars, so mitochondrial diabetes. This graphic is from our colleagues in the UK that use this mnemonic of the 5 T's to remember symptoms that could be suggestive of diabetes. So excessive thirst, when blood sugar exceeds around 180 or 200 milligrams per deciliter, that's the units we use most commonly in the US, then it spills into the kidney, into the urine, and it causes increased urine volume. And so folks pee more, that's toilet, and they become more thirsty. I'll mention in folks with mitochondrial disorders who may have kidney problems, the kidney threshold for spilling glucose into the urine may be lower, so they may spill glucose into the urine at even lower blood sugars than others might. Feeling fatigued, that can have so many causes, as people know, but new fatigue or a change, blood sugar fluctuations might be a cause. Unintentional weight loss, of course, can have lots of causes as well, diabetes being one of them. And there are tests, so testing blood sugar, testing metrics of average blood sugar, like hemoglobin A1C, fructosamine, glycated albumin. There's ways to assess blood sugar to see if diabetes is present. And there are high blood sugar conditions that are emergencies, diabetic ketoacidosis, when acids accumulate as a result of lack of insulin, and hyperosmolar hyperglycemia, when the blood sugar gets so high that it has dangerous effects potentially on the brain. So I'm sharing some case examples. These cases are adapted from patients we've taken care of. Some of the identifying details have been changed. So this is a little girl with single large-scale mitochondrial DNA deletion syndrome. The acronym is shown there. Amy Goldstein can pronounce it. I can't, so I just tell you what it is. Folks with mitochondrial DNA deletion syndromes seem to be at much higher risk for endocrine disorders than others. So our clinical practice at CHOP in the endocrine program, seeing mitochondrial disease patients is enriched in these folks. So this little girl was diagnosed with hypoparathyroidism, so low calcium levels because of a problem with the hormone that regulates calcium at 4 years of age. She came to attention in endocrinology because of short stature. So this is her height curve. And you can see that she started to kind of fall off around age 8, which is not unusual for kids with mitochondrial disease. And in some individuals can be first manifestation. And then by 10 years old, she was diagnosed with mitochondrial diabetes. And this is her BMI chart on the right. And anyone familiar with looking at the BMI chart will see that the BMI was kind of getting lower and lower and lower relative to the age norms, and then went up. And that coincided with placement of a gastrostomy tube for extra nutrition. And that placement was absolutely appropriate. This child really needed extra nutrition and to help her be more robust and recover from illnesses. But one thing we anticipate that sometimes happens when the nutritional status improves is that the pancreas that makes insulin to help deal with the carbohydrates in the food that we eat can no longer keep up with the demand. And so we had given this family a glucometer, a machine to check blood sugar, because we knew that this might be a time that she'd be vulnerable to present with diabetes. And so she did present with diabetes with high blood sugar that required insulin treatment, but fortunately she was not very sick from her diabetes because her family had been monitoring blood sugar there. She had a number of other health concerns associated with mitochondrial disease that I'm listing here for you, including relevant to her diabetes management, pancreatic insufficiency, which means that it is difficult for her to digest nutrients without additional enzymes, a history of pancreatitis, renal insufficiency. So kidney problems can affect how insulin is metabolized in the body, so often requires dose adjustments. Also heart block and hypoparathyroidism. So diabetes, if uncontrolled, can affect electrolytes in the body, which also can affect these other things. So everything goes together, everything's quite complex, but with a good understanding, this can be managed and can help folks feel better. So that's one example. When I'm asked about mitochondrial diabetes, one question I get all the time is mitochondrial diabetes type 1 or type 2? So first thing I'll mention is that in folks with mitochondrial disease, I think of diabetes per se as kind of the tip of the iceberg. So a small fraction of people, or depending on the series, 10%, 20% may meet criteria for diabetes. But a lot more have abnormal blood sugars that may, for example, only manifest when they're sick. Now, you all know that in the US, diabetes itself is very common. By most recent CDC estimates, 37 million individuals with diabetes and 96 million with pre-diabetes. And our current diagnostic framework for diabetes really doesn't work very well, in as much as it doesn't give us really great guidance with respect to the most appropriate choice of therapy. It does to some extent, but there's a lot of room for improvement. So type 1 is traditionally considered autoimmune diabetes. So it's a small fraction of the kind of diabetes we see. Most often presents in childhood, but not always. And it's when the immune system, for reasons we don't entirely understand, attacks the cells of the pancreas that produce insulin. So children, for example, with autoimmune type 1 diabetes require insulin replacement. Type 2 diabetes is the one that we may think of out of the textbook as being related to excess weight or inactivity, but it's also itself very heterogeneous. People are very different from each other. And many individuals with type 2 diabetes actually do end up requiring insulin. So a lot of people, when they think of, is this type 1 diabetes, they mean, does this person require insulin? And actually, that's not the same as type 1 versus type 2. Virtually all individuals with type 1 will need insulin. A substantial proportion of those with type 2 will need insulin, but they're a little bit different. I think of mitochondrial diabetes as its own entity, because for reasons that we can discuss in detail if folks are interested, there are molecular bases for why folks with mitochondrial diabetes develop that condition more readily. This is a different case of a child with mitochondrial diabetes. This is a 6-year-old who presented with excess urination and thirst, 2 of those symptoms that I remembered, had a very high blood sugar. So blood sugar, a random blood sugar with symptoms that's above 200 is consistent with diabetes. Hemoglobin A1C, you may be familiar with this lab if someone has sent this testing for you. This is how much sugar is attached to a hemoglobin molecule. So you can, if folks have diabetes, then their blood is like swimming in higher amounts of sugar all the time. So more and more sugar gloms onto that hemoglobin. And so it will be higher, it will be sweeter than most. So this individual had a higher hemoglobin A1C. We don't always use, or we don't always use this hemoglobin A1C measurement alone in folks with mitochondrial disorders. And that's because if red blood cell turnover is not normal, then this value may be misleading. So some individuals, for example, with Pearson's or other forms of anemia, we add additional tests to the A1C, tests like fructosamine or glycated albumin, that we can interpret even in people whose red blood cells may not be typical. And someone presents with diabetes, we're interested in whether or not they're making ketones. So ketones is a byproduct of when the body is breaking down fat for energy, when carbohydrate's not available, which it's not available in the tissues when insulin's not there. Ketones are acidic and can build up and make folks sick. Some folks adding complexity with mitochondrial diabetes don't make ketones as readily because they have secondary fatty acid oxidation problems. But the presence or absence of ketones really helps us decide how aggressive we need to be with our therapy. This child had no anti-pancreatic autoantibodies. We do test for these in all of our patients with presumed mitochondrial diabetes to look for evidence of autoimmunity. It should be illegal, but it's not to have more than one condition. So to have kind of an autoimmune picture of diabetes and a mitochondrial form of diabetes. If you have anti-pancreatic autoantibodies, that would be an indication that insulin is even more likely to be needed. This child certainly met criteria for starting insulin because she was dehydrated, had a very high A1C, and as a child, typically will end up needing insulin as therapy. She had some of the other heart problems that and other issues that have been described before and ended up being diagnosed with mitochondrial DNA deletion. So thinking about this beyond kind of typical type 1 and 2, here's the kind of general population in blue, folks with the quote unquote garden variety diabetes in red, and then folks with mitochondrial diabetes here in green. By some population estimates, up to 5% of like what is presumed type 2 or type 1 even may be a mitochondrial form of diabetes or may have a mitochondrial contribution. Diabetes, in my experience, really most common in the mitochondrial DNA deletions like current Sayer, but it occurs in other conditions, including from nuclear mutations, Pol gamma or M2B, OPA1. Kids tend to have a more acute onset and more a picture consistent with insulin deficiency, like diabetic ketoacidosis. In adults, it can present that way for sure, but can have a more insidious onset and more features of insulin resistance. Still, it occurs at a lower body mass index, so with less amount of obesity at an earlier age than what we might think of as typical type 2 diabetes. And over time, we know that folks with diabetes can develop complications. There tend to be less problems in the retina and more problems in the kidney and the nerves than in other forms of diabetes, which may make sense given the other underlying problems that we see. So this is the ADA 23, American Diabetes Association 2023 guidelines for intensification of therapy in folks with presumed type 2 diabetes. And I show this schematic not to make you memorize it, but to illustrate two things. One is there are a lot more agents that we have to choose from in treating diabetes these days than even when I started as a fellow, which was long ago, but not that long ago. But the second thing to mention is there's no mitochondrial disease header here, right? So I'll get to a schematic in a few slides with some suggested regimens, but there's a lot of great new agents. None of them was without side effects. So we have more choices, but we also have more unknowns. And I think the decision of which agent to use really requires a careful discussion of how the risk-benefit ratio of each of these therapies applies in a particular person. The most important decision we face therapeutically when you're meeting someone with diabetes is like, does this individual need insulin therapy? So the rules of thumb, if someone shows up with diabetic ketoacidosis, that's that complication where ketones have built up, or blood sugars that are so high that they cause dehydration or weight loss, those are reasons for insulin. I'm reminded to mention here, insulin therapy essentially refeeds the cells, so the cells that have been starved of nutrition. But as a result, there's a lot of electrolyte derangements like potassium, phosphorus after initiation of insulin that need to be addressed. So the cells need to be refed, but they just need all the electrolytes to go along with them. Considering the new drugs is really appropriate. We want to be thoughtful about avoiding low blood sugars. We know folks with mitochondrial disorders can have difficulty with absorbing nutrients if they have gut problems. Some of them have liver issues or have other difficulties in the response to hypoglycemia, so they may be more vulnerable to lows. We also don't want the development of ketones because that acid-base derangement really isn't something anyone tolerates well, but particularly folks with underlying conditions. And definitely using technology. So I get asked often if folks with mitochondrial disease are good candidates, if they have diabetes, for continuous glucose monitors or insulin pumps, and absolutely those technologies are real game changers. So everyone probably watched the Super Bowl and saw Nick Jonas advertising his continuous glucose monitor. It is really amazing being able to monitor diabetes, blood sugars continuously, and for parents to be able to see blood sugars on their phones, for example, for their kids. There's solutions that exist for those with vision and mobility impairment as well. For example, like we have insulin pens that can speak the dose as the dose is being dialed. There are also a lot of different forms of glucagon. So glucagon, to remind you, is one hormone that increases blood sugar. So it's kept on hand for folks with diabetes in case too much insulin is given and an individual is not able to take carbohydrate by mouth or by G-tube or another way to bring blood sugar up. There used to be just a powder and a liquid, but now there's an intranasal form, there's a premixed form, lots of different ways to keep blood sugar safe. Technologies I mentioned are appropriate, and there are around and in development automated insulin delivery systems that help adjust insulin delivery in response to blood sugar. So all really amazing technology. This is the schematic I mentioned. That's a nice summary of screening and therapy possibilities. It's just a good opportunity to summarize where we are so far. So I didn't go a whole lot into pathophysiology earlier, but just to give you some intuition, why we think mitochondrial disease produces diabetes disproportionately, to kind of oversimplify a huge literature. Secretion of insulin in the pancreas requires mitochondrial ATP production. So when the pancreatic beta cells see glucose is used to produce ATP, and that's what leads to insulin secretion. So if the glucose to ATP coupling process is not working, then insulin deficiency can develop. Also, there's what's called insulin resistance, particularly in adults, but sometimes in children as well, where the effects of insulin, particularly in muscle, for example, are less. So more insulin is required in order for glucose to be used for energy. So our practice in clinic is to educate folks regarding symptoms. So you're participating in that right now. To screen at least annually, we do random blood sugars, we do hemoglobin A1Cs or other metrics. This schematic uses an oral glucose tolerance test. I tend to not do that. That's the test where you drink sugar and measure blood sugar periodically. We do that in the research setting, but I find a lot of folks don't tolerate it. So instead, I sometimes give people a glucometer and have them make more frequent measurements at home if I want to get a better sense beyond the one point in time. We manage folks who are diagnosed with diabetes based on physiology, including blood ketone measurements. So folks with diabetes, we first decide whether or not insulin is indicated. And then if it's not, if we can proceed without it, then if folks have kind of a type 2 phenotype where excess weight gain is a concern and there's signs of insulin resistance, then we may consider a novel agent. We tend to avoid metformin given the risk of lactic acidosis in some individuals with mitochondrial disorders, and also because there's more agents available. And we, of course, need to continue to revisit whether or not insulin is going to be appropriate. And I already mentioned to use technology. So the other side of high blood sugar is low blood sugar, which can be a complication of diabetes treatment or can arise just on its own. So symptoms of hypoglycemia are pretty non-specific, but folks can be sweaty, shaky, pale, and if severe or prolonged, can lead to seizure and unresponsiveness. That is those symptoms that are reversible with carbohydrate. So this sign is up in the resident room on the 5th floor of inpatient side at CHOP. And it says always, but not often, but not always push D10. So that's dextrose containing fluids. There are some subtypes of mitochondrial disease, and if you have one, you would likely know it, where too much dextrose can be more harmful. But in general, if the blood sugar is low, the safest thing to do is to treat it. So it's good to know ahead of time. We always look for treatable causes if someone presents with a low blood sugar. Really often, prolonged malnutrition or sickness can be a cause. Deficiency of the adrenal hormone cortisol, which I'll get to in a moment, and certainly liver problems, because liver is where we store carbohydrate, and liver is also where we make new glucose in situations of limited nutrient availability. We reverse catabolism, meaning instead of breaking down tissues for energy, we try to give nutrients back, and ideally having an emergency plan so folks who are known to develop hypoglycemia or to be at risk are to have a plan in place to know what to do if that were to happen. So just kind of hypoglycemia 101, when we're evaluating someone as endocrinologists for hypoglycemia, we divide that into ketotic or non-ketotic, which means is the hypoglycemia occurring while someone is burning fat for energy, in which they would produce a substance called ketones. We also kind of divide hypoglycemia into fasting or reactive, meaning did the low blood sugar occur after prolonged time without nutrition, or did the hypoglycemia occur shortly after a meal? And I'll mention two things about ketones. Some individuals, I mentioned this earlier, with mitochondrial disorders have kind of secondary problems of fatty acid oxidation and can't produce ketones as readily. So people can have a fasting hypoglycemia with inadequate ketone production or ketone production that's less than expected. The other thing I'll mention, both in folks with diabetes and when we do the hypoglycemia evaluation, there are several different ketone bodies, and beta hydroxybutyrate is the one that we measure with a point of care blood ketone meter. The urine ketone measurements are acetoacetate, and the conversion of beta hydroxybutyrate to acetoacetate doesn't always proceed in the typical way in folks with mitochondrial disease. So the urine assays sometimes underestimate the degree of ketosis. Also, asking someone who's not feeling well to collect a urine specimen and then kind of squint at a stick to see how much ketones is there is just a lot to ask. And the ketone measurement in the urine is even more dependent on the person's hydration. So the blood ketone meters and strips are more expensive, but we tend to favor those and try to get them approved if we can. So this is, I'll just mention very briefly, a study that Patrick Hanley, one of our former fellows now attending at Nemours, did, looking at fasting tolerance in folks with mitochondrial disease. So in some kids at CHOP, we do controlled fasting studies, and I would emphasize this is only appropriate in the inpatient setting when we're trying to ask specific questions, including how long is safe for a person to fast. And if we really need to understand better how to manage hypoglycemia, then we can fast individuals for a short time to kind of provoke it and see what makes sense to do. And in folks with mitochondrial disease, as we might expect, compared to kind of all others with a ketotic hypoglycemia profile, fasting time was less, and they seem to produce fewer ketones, which makes sense with what we know about the condition. So if someone presents with a concern for hypoglycemia, we usually give them a glucometer and have them check blood sugars if they're ever experiencing symptoms and after the longest time without eating, because that's when they're usually most vulnerable. Our goal blood sugars are at least 70 milligrams per deciliter. Less than 50 is an emergency. We have folks check ketones, again, in blood and not in urine. And the next steps is really based on their findings. And I know this group is, you're attending a talk on endocrine problems, so you're probably very savvy about this, but watching out for NPO status. So NPO means nil per os, or nothing by mouth. Folks who are getting ready for imaging studies or operations may be asked to fast for those. always worth discussing with your care team if you're being asked to fast longer than the usual time. So say you usually fast overnight, if you're being asked to fast throughout the rest of the next day, for example, whether or not that's something that's appropriate for you or whether or not a plan needs to be revisited. So switching gears a little bit, but to a condition that can manifest with low blood sugars, adrenal insufficiency. So the adrenal glands are the ones that, this is a schematic here, they sit right above the kidney and they make a hormone called cortisol in response to stressors like low blood sugar, low blood pressure, surgery, fever, or injury. It really shouldn't be surprising to all of us that cortisol deficiency can be a manifestation of mitochondrial disease because mitochondria are critical for steroid hormone synthesis. So the way this works is if these stressors exist, then the hypothalamus and the pituitary produce a hormone called ACTH that stimulates the adrenal gland to make cortisol. And if you don't have enough cortisol around, you can have low blood sugar, low blood pressure, and low sodium levels, especially in the setting of critical illness. And this is a schematic that I share with our medical students, but I think worth mentioning for folks to understand a little more about adrenal glands and the adrenal insufficiency. So this is like the way the adrenal gland looks, a cartoon obviously under the microscope, but there's an outer cortex and an inner medulla. And the outer cortex actually makes 3 different adrenal hormones, and not everyone with adrenal insufficiency is missing each of these. So it's helpful for us as endocrinologists to make sure we understand if someone has adrenal insufficiency, what kind of adrenal hormone they are missing, because that determines what we should give them back. So glucocorticoids are produced here in this middle layer, that's cortisol, and medicines used to replace these might be hydrocortisone or prednisone. In this outer layer, a hormone called aldosterone or mineralocorticoid, which helps with salt and water balance, which helps with individuals staying hydrated. If you're missing that hormone, you're particularly vulnerable to dehydration, low sodium levels, and high potassium levels. And a medicine called fludrocortisone or Florinef is what we would prescribe. This inner layer it produces androgens, so hormones with male-like effects, DHEA, DHEAS, you may have heard of. We don't tend to replace these, but we sometimes measure them as part of our testing to understand why levels may be deficient. And then the innermost layer of the adrenal gland is the medulla that produces catecholamines. That's like adrenaline, your fight, flight, or freeze response. So all of these can be affected. The way we screen for adrenal insufficiency, if we really suspect a problem, is to do an 8 a.m. set of labs. These don't need to be fasting, but cortisol is a diurnal hormone, meaning it changes by time of day. So we measure a level of ACTH and cortisol. And sometimes we also measure aldosterone and renin if we suspect mineralocorticoid deficiency as well, and DHEAS, which is this androgen. For some folks where the screening test doesn't give clarity with respect to the diagnosis, we do something called provocative testing, where we give a dose of ACTH, that pituitary hormone, in the hospital in a monitored setting, and we see, does the individual's adrenal gland make cortisol the way it should? And then we have to decide, do they need glucocorticoid only? Do they need glucocorticoid and mineralocorticoid? What formulation? How much do they get every day? And then what should their stress dose plan be? Because the cortisol, our bodies need a little bit every day, and we need more when we're sick or stressed. And so we have kind of 2 dose plans, one for kind of day to day and one for more. We also have to be careful we don't give too much steroid, because there are definitely side effects of too much steroid. And you may have heard of Cushing's. Cushing's syndrome is just a phenomenon of too much steroid from a variety of causes. But iatrogenic, meaning from medicine, is common, and we want to avoid that because of things like high blood sugar, fragile bones, poor sleep, poor mood. Like those are all common problems that can be made worse by high doses of steroids. So when we think about who needs testing, folks who have received high doses of steroid medications for other reasons, particularly for when they, more than a few weeks, for example, for asthma, for breathing problems, their own adrenal glands can be adversely affected, meaning their capacity to make steroid hormone can be impaired. That capacity tends to recover, but while it's recovering, then we need to be thoughtful about a safety plan. Individuals with suggestive symptoms, this is a really tough one because things like fatigue and nausea and difficulty recovering from illness are so prevalent. We tend to not have our mitochondrial colleagues screen for adrenal insufficiency independently. Instead, if they really have someone whose symptoms seem beyond typical, have them refer to endocrine because that testing is not always straightforward. I'm putting this table here of characteristics of pediatric ICU patients with and without mitochondrial disease. So mitochondrial disease is a risk factor for less good outcomes in the ICU. I'm mentioning this because sometimes when kids are very sick in the ICU, and we'll hear that empiric stress steroids, meaning just in case this child has adrenal insufficiency, we're giving them higher doses of steroid to cover them. This is just a few slides on growth, turning back to the patient that I mentioned in the beginning. I mentioned this in the context of blood sugar because when growth hormone deficiency is severe, and usually that would be in the neonatal period, but when it's bad, it can also lead to lower blood sugars. So it's not surprising that the growth is often impaired in folks with mitochondrial disease of diverse causes because growth requires energy. It's a really energy consuming process. And this is an example case here. You can see the growth chart similar to our patient where they fell off the chart at kind of 7 or 8 years of age, and can be the presenting feature of a mitochondrial disease. This is work that we did kind of modeling growth and development in kids with mitochondrial disorders who are shown in the blue-green compared to a control group in red. So both in girls and in boys, particularly at the time of puberty, it seems like on average, kids with mitochondrial disease are not able to mount that same pubertal growth spurt. Lots of causes of impaired growth. Some are nutrition and GI. We've looked at body mass index, meaning how much weight relative to height, as well as height itself. And certainly low BMI can be a cause. Other endocrine problems could contribute. Growth hormone deficiency may be a contributor, but also we wonder if stress or an adaptation to stress. In other words, if the child's body is staying small because of the energetic requirements of growth, and that short stature may be somewhat adaptive to a condition where energy availability may be limited. This question I get all the time, and it's certainly not I'm not going to cover the whole complex conversation in one slide, but I'm going to try so you can understand if this is a decision you're facing, what to review with your own team. We get asked a question a lot about whether or not to treat with growth hormone if growth hormone deficiency is suspected. So in kids, for example, with short stature or decreased growth velocity, meaning not growing quickly, low blood sugar, fatigue, decreased muscle mass, or low bone density all can reflect growth hormone deficiency. We certainly exclude or mitigate other causes. IGF-1 and IGF-BP3 are growth factors. GDF-15 can also be an indicator of stress. And then there's provocative testing, additional testing we can do for growth hormone deficiency. The growth hormone comes in adult or pediatric doses. So even us as adults, if we're not growing anymore, we still make growth hormone, although at a fraction of the dose that or the amount that we make as children. So sometimes we replace growth hormone even in adults to keep up the muscle and bone benefits as well as for energy. So growth hormone has a lot of benefits, and replacing it in someone who's very deficient, it often is reasonable to consider. However, there are side effects as well, or other effects based on how it works. So more growth may be difficult to sustain for an individual who is under kind of chronic energetic stress. Growth hormone also increases blood sugar. So folks who are vulnerable to diabetes, that can sometimes tip them off. So we certainly monitor blood sugar closely in folks with mitochondrial disorders in whom we are treating with growth hormone. So we have a really specific discussion in the context of the particular patient of risk and benefit balance and what the person's and the family's preferences are, and then manage expectations with respect to the magnitude of the benefit that they might expect. So I hope I persuaded you endocrine disorders are prevalent in individuals with mitochondrial disease, and that evidence-supported and symptom-directed screening is appropriate, and always great to identify opportunities for intervention. I have a few slides from Dr. Weber, who sends his best just a kind of bone health 101 before we open up to the questions that I see accumulating. So DEXA scan, folks may not be familiar. This is the way in which we measure bone density. It is ionizing radiation. We say around as much as a flight across the country. It measures bone density, and lower bone density often is related to a higher fracture risk. So that's why we care about low bone density, because it can mean people break bones, which is functionally really significant, really painful, and can set folks back health-wise in a big way. We report our result as a Z-score, meaning standard deviations above or below the mean. So a score of 0 is average, and then -2 or less is frankly low. And the decision of when to do a DEXA is really based on risk. So if someone has had a fracture that we think might reflect low bone density, and we think we may want to treat with medicines, then we consider a DEXA scan. And sometimes we'll do one towards the end of puberty into adulthood to get a baseline measurement. Spine x-rays we sometimes do as well. They serve two purposes. One is to look more closely for scoliosis. We suspect that. Also is sometimes the DEXA scan can't pick up or incorrectly estimates the bone density in the vertebrae and the backbone because of a compression fracture. So if the bones are squished, they may appear more dense, but that's actually not a good reason for being more dense. It's more dense because they're broken from being squished. Those compression fractures may be painful, but sometimes they're occult, sometimes they're not visible otherwise. So this is an example of one of those compressions, and that can be a signal that the bones are weak and a medicine may be needed. So keeping bones healthy, we often check vitamin D levels, getting enough calcium from the diet. We know dairy is not tolerated by everyone, but there are some sources, both dairy and non-dairy. And then we often talk with our patients about whether or not they're getting enough calcium, and if they're not, consider ways to supplement. So there's bisphosphonates, which you may have heard of, Zometa, which is a really common medicine that's used in the case of fractures, where our goal is to prevent another fracture. But there are other medicines besides bisphosphonates, particularly in older adults, that merit discussion. So we tend to consider these in kids if they've had a fracture, where we know that they're likely to have a fracture again if we don't treat. And then we sometimes consider here in this setting where maybe they haven't fractured, but their bone density is getting worse at a developmental time when we would expect the bone density to be getting better. All right, so lots of resources, including CHOP, Mitochondrial Med Society, UMDF is a great resource. I think I'm going to stop sharing. Is that okay, so that we can start Q&A?
That sounds like a wonderful plan. I'm going to preface the Q&A today. We do have a lot of questions. I will be trying to get to as many as possible. Please know that I may paraphrase your question in order to simplify it so that we can get to as many as possible today. So this is going to be like a little bit like quick fire, Dr. McCormick, so that we can get through as many as possible. There are a few that I have reserved for you to answer post-event when the authors have requested anonymity. So state that. And for everybody else, in case we don't get to your question, we will be doing our very best to get them answered post-event. If your question did not have anything to do with endocrine issues, we'll save that for some other time where it fits a little bit better. So to get started, do any supplements help regulate blood sugar? I thought that was a really good question.
What a good question. I have had people ask me about specific ones, and I think, for example, in Dr. Scalia's citrulline study, I'm really curious what citrulline will do to blood sugar. So we've actually asked him to look in the folks that he studied who have diabetes. Arginine we use to stimulate insulin secretion in research settings. So we know arginine may have a blood sugar modulatory effect. So those are two supplements that I can think of that may have effects. But the short answer to the questioner is that there's none that we prescribe because we think it's going to help
Okay.
blood sugar. But
And it sounds
indirectly,
like we're learning about it too.
we are absolutely learning about it. And if some supplements make you feel better and you exercise more or you eat better, like that could have indirect effects for sure.
Perfect. And this is a question about something you spoke of earlier. And the question was, were there, what were the 2 tests with blood disorders?
Oh, so besides hemoglobin A1C, there are 2 we use at CHOP and probably elsewhere too, fructosamine and glycated albumin. But I think the point is, if you don't have normal hemoglobin or normal red cells, those are 2 tests. There are others, but those are 2 that we often use to test for chronically high blood sugar.
Right, that definitely is helpful. Okay, let me see. Are there any foods that you feel like stabilize the endocrine system?
Wow, what a great and complicated question. I think that depends on the person and what they're doing. In general, unless someone's about to exercise or if their blood sugar is low, many of our patients find that simple carbohydrates by themselves, so like simple sugars, can sometimes cause the blood sugar to go up and sometimes back down again. So if you need that because your blood sugar is low, or you're about to exercise and you need something simple and easy to digest, we sometimes say maybe pairing simple carbohydrates with some protein or fat to prevent those patterns. But we know from research everybody's body responds a little differently to nutrition. So maybe something worth learning about yourself, how different foods affect your blood sugars.
This was an interesting one that we get a lot in the Mito space because it's just hard finding doctors, but this one's very specific to endocrine. It's harder to find an endocrinologist until you have the documented endocrine disorder. So very often the person has to go through the gatekeeper of primary care. What would a person that had maybe some concerns, what would they do? Would they sit down with their primary care and ask for a referral? How does that usually happen? How do people get to you?
Well, I'm kind of lucky because I work with the Mito program at CHOP, and so they would refer me usually. But I have to say, if you go to a Mito doctor and they can help say, based on your genetic disease or based on some of these symptoms, like if that referral comes from them, that can often be really helpful. So primary doctor may be one, but to my mind, Mito doctor is the best. If you're lucky enough to have a care team that can refer you or help formulate the specific questions that you want endocrine to answer. Because sometimes we get this, like, is growth hormone appropriate for this individual? Or does this individual need a DEXA scan for low bone density? Sometimes helping to distill the question, because when the primary doctor has to fill out a referral, she has to write like, what is it for? And so if she has help doing that, then that can be really useful.
That makes sense. Okay, question. And this is a 2-part question that I've combined 2 that I've seen. What about Ozempic and what about metformin?
Yeah. Okay. So metformin first. Metformin used to be first line for individuals with diabetes, like type 2 phenotype related to excess weight and insulin resistance. So once you decide someone does not need insulin right away. One of the side effects of metformin can be lactic acidosis, particularly in the setting of dehydration. So someone with a personal history of lactic acidosis, which many of your audience members may have, like metformin, we consider an absolute contraindication. Most folks will try to avoid metformin in people with mitochondrial disorders because you don't want the first time they have lactic acidosis to be, in the setting of metformin use. And it used to be that there weren't a lot of non-insulin alternatives to try first, but now there are, right? So Ozempic is one of them. Ozempic is a member of a family of medicines called glucagon-like peptide receptor agonists, and we abbreviate that GLP-1 receptor agonists. One, Rybelsus is semaglutide, is available orally, but there's a whole family, subcutaneous injections, like meaning a little shot daily or weekly. Those are most appropriate for individuals who also want to lose weight. So people who are normal weight or don't want to lose or don't need to lose weight or can't lose weight, that's not appropriate. So if we think excess weight's contributing, then that might be medicine to consider. It can produce nausea and kind of easy fullness. So the GI symptoms are things that folks with mitochondrial disease may already experience. So that's something to be aware of, especially in the titration time. Metformin does that too, by the way. GLPs can also cause pancreatitis. So folks who may be vulnerable already, I do, and I know my colleagues do, screen for pancreatic enzymes before even starting, because some folks with mitochondrial disease have subclinical pancreatitis. So if there's that there, then we tend to be thoughtful about it. Everyone has a titration upward plan. And if we do use it in some folks with mitochondrial disorders who may GI wise have, or weight wise, like for where that might be safe or appropriate for them to try, we would start at a very low dose and not usually titrate as quickly as we might in someone without a mitochondrial disease.
Mhm.
And we often follow pancreatic enzymes too. So you can tell a lot of discussion. The other the class that you haven't asked about, but it's important, is SGLT2 inhibitors, dapagliflozin, canagliflozin, empagliflozin, so anything that ends in gliflozin. Really a game changer, because folks with cardiomyopathy, heart failure can also really be helped by those. Side effects are a consideration there too, because you can develop ketones more easily. So we monitor ketones before we consider starting that medicine. Also, it increases the amount of sugar in the urine, so people can have more urinary tract infections or fungal infections. So that history is important. So knowing those are the two other classes, the SGLT2s and the GLP-1s, that are really terrific for the people for whom they are appropriate. But you got to like start screening and monitor very closely as they're being given to see if someone's a good fit.
One of the other questions that came through was about a good result with Ozempic in control of the diabetes, but now there's some concern about kidneys. Is that something we see sometimes with that medicine?
Do you know, SGLT2s maybe more, but I mean, I'm without knowing the detail of what the kidney concern has been. I mean, sometimes folks on GLPs will be like not thirsty, and so maybe they will not be able to stay as hydrated, especially also if they have like upset stomach, or if more fluid in their stomach might make them feel fuller. So I wonder if that's what's happening in the person. It's not one we typically think of outside dehydration or like subclinical dehydration.
I have another question about someone with adrenal insufficiency, and there are you had talked about the different specific steroids and testing. Is that someone that anyone that has been diagnosed with adrenal insufficiency should be thinking about getting that test completed?
Well, if you're, maybe I wasn't clear when I was talking about, but like that's how we get to the diagnosis of adrenal insufficiency, is that testing. Does that make sense?
Okay. So they should have it, even if it's just suspected. That's the testing that would make sure that it was confirmed.
I think so. I think I follow your question, but tell me if I don't. But like in the ICU, for example, if someone's critically ill, we often just give steroids because they're so sick that we can't like think about the testing. But otherwise, before committing people to steroids, which have side effects, right, it's important to test and make sure they need them, and what kind do they need.
Okay, perfect.
Okay.
All right. Let me get on to we've got just a couple more minutes. I'm going to get to as many as possible. And I think you got to this, but how would a person with children identify growth hormone deficiency? It's just it's a fairly simple process of testing, correct?
Not so simple. I mean, I think if someone's concerned about that, then endocrinologist is usually the way to start, who starts with like reviewing the growth chart and a bone age x-ray, and x-ray of the hand, and some growth factors and other blood tests are usually the first step. There is more sophisticated, what's called provocative testing, meaning like where we give a medicine and we see what's the growth hormone response. That's more involved, but often helpful to really get clarity about whether or not that's the answer.
This is a really it's probably a too big of question, but Hashimoto's and Mito, what have you been seeing there? What should those folks be doing?
I agree with you, really great question. The challenge with detecting an association with Mito broadly writ is that Hashimoto's is really common in the general population too. So when we try to say is it more common? I suspect in some subtypes that Hashimoto's is when there's autoimmune activity against the thyroid. The challenge can be that you sometimes have the evidence of the autoimmunity, meaning the immune system's got activated against the thyroid, but the thyroid function may or may not be compromised. And how do people feel? Do we decide to treat that with thyroid hormone or not? Can be kind of what's the threshold to treat? That can be a complicated question. Usually the question is, do we treat or not? And that requires blood measurements and often an evaluation.
All right, here's a question that I think many people may benefit from. Is there a certain time of day that's best to test for ketones?
Well, it depends on why you're testing for ketones, right? So if someone has high blood sugar and you're concerned about risk for diabetic ketoacidosis, you test whenever the high blood sugar is there, right? So if you're testing for ketones in the context of a hypoglycemia evaluation, then you might check for ketones after the longest time without eating. For most people, that would be in the morning after not eating overnight, but people have all sorts of different eating habits.
Right. Well, let me see if there's any more that we have time for. I think it might be time to wrap up.
We were doing so good, the numbers went down, but then they kept.
I know people, but some of the questions you're answering as we're going, and they haven't been removed yet.
Okay.
Very specific questions that I don't know that would be appropriate for the whole group. Oh, here's one though. This would be more for your colleague, but if we can touch on it real quick before we end. Common causes of bone pain. Are those related to mitochondrial disease, and are they related to the endocrine system?
Oh, bone pain, what a good question. I mean, as an endocrinologist, I think probably just about any endocrinopathy, if it were profound, I think a vitamin D deficiency can make people, usually muscle weakness, but lots of causes for muscle weakness. As an endocrinologist, I think of bone pain, I'm like, oh, is there an occult fracture? But I'm imagining your questioner means kind of like head to toe, systemic, pain. And I don't think there's one deficiency more than another that kind of produces that. I would, with the exception of there's really profound fatigue and discomfort with abnormal calcium levels. But again, people are so different. They may experience discomfort for all different reasons.
All right. Well, I think it's time for us to wrap up. Thank you. That was a lot of questions, and we'll be sending some off to you post-event. So for those of you that are on the line, we will be trying our best to get your questions answered after we're done. What an interesting topic, and what a topic that I think many of our families need to know about. What I learned is that, and you could correct me, Dr. McCormick, that most of our families should be at least checking in on their blood sugar and making sure they know this.
Well, I think once again, hopefully everyone has a great Mito doc who can advise them if that's something they can do. But I have, if people have suggestive symptoms, then a focused assessment, not necessarily Dr. McCormick says everyone has to have glucometer, not necessarily, but if you have questions or symptoms that are suggestive, it is a way to say, oh, I'm going to check my blood sugar. Is this lead me down that path? Or does it say, blood sugars are really robust. It seems like we should be looking for other causes.
Wonderful. Well, thank you so much, Dr. McCormick. It's been wonderful.
Thank you for these terrific questions. These are great.
Yeah, and for families, just know that this will be recorded and will appear on our YouTube channel and in Mito U, probably by next week. At the latest. And also want to let you know that our next Ask the Mito Doc will be Wednesday, May 17th from 7 to 8 p.m. And the name of the topic is Ask the Mito Doc webcast series, special session for the newly diagnosed. But I do want to encourage anyone that's considering attending symposium to make sure you attend this session, because we're going to be given the basics so that you'll be ready for the more advanced learning that's happening at the symposium. And then on Saturday, June 1st from 10:30 to 11:30 a.m., Our UMGF Ask the Mito Doc webcast will be live at Mitochondrial Medicine 2023. This will be a combined session for both our pediatric families and our adults, where we have a giant list of doctors that are participating, and I think it's going to be a really good thing. So we look forward to seeing you all next month, and look forward to seeing you at Mitochondrial Medicine 2023. Thank you, everybody, and we'll see you next month.
Thank you so much. Good night.